Okay, so today I feel like talking about the impression materials, classification of impression materials, and application features of impression materials in clinical practice. So, impression materials are used to copy the teeth and surrounding oral structures by creating a dental impression, powered with dental plaster to fabricate a dental cast. This procedure provides a three-dimensional and accurate mouth replica, allowing dental work even in the absence of the patient. Dental models enable dentists to perform a better diagnosis and treatment planning, since the teeth can be meticulously visualized and studied from angles that are difficult to see in the patient's mouth. Particular treatment, such as removable and fixed prostheses, can be executed thanks to dental casts. The final restoration of prosthesis fit depends on how accurately the impression material has recorded the tissue details. History of impression materials. Wax was the only impression material used in dentistry until the mid-19th century, when gutta percha first appeared. Then in 1857, Charles Stent created a thermoplastic modeling compound similar to today's impression compound. Still, the problem with this material was that it was rigid and could not reproduce undercut areas. All the impression materials used until that date became rigid after setting and could not copy the oral tissues accurately. Thus, there was always a need for an impression material that could remain elastic even after setting. That is when agar, a reversible heterocolloid manufactured from alga, was introduced in dentistry. Although this jelly-like material was elastic, it required a complicated procedure to be used as an impression material. When the algae used to manufacture agar was unavailable during the Second World War, Americans used local algae to manufacture another elastic impression material, known as alginate, which has gained popularity since then. Alginate and agar have disadvantages like dimensional instability and low tear strength, which led to the manufacture of elastomeric, also known as rubber-based impression materials. First came polysulfide, then condensation silicone, followed by polyethylene, and then by addition silicones. Now a few words about the function of impression materials. Dental impression materials are used to copy the oral tissues, create a dental impression, and then pour gypsum into them to produce a dental cast. An LLCAS is used to analyze and diagnose a clinical case, manufacture removable and fixed prostheses, and build occlusal spleens and mouth guards. Beyond the teeth, impression materials are utilized to fabricate maxillofacial prostheses, such as obturators, for example, maxillectomy and cleft lip and palate, or ear prostheses and prostheses of the eyes. Here is the classification of impression materials. Based on use, they are divided into for primary impressions, for example, alginate, impression compound, and elastomeric putty, and for secondary impressions, like the light body elastomers and zinc oxide eugenol. Based on setting reaction, they are reversible and irreversible. Reversible are also called physical. They are impression compound, impression waxes, and agar. Irreversible, or they're also called as chemical, they are alginate, impression plaster, elastomeric impression materials. Based on the state of the impression material after setting in the oral cavity, they are rigid and elastic. Very rigid. Impression compound, zinc oxide eugenol, impression plaster, and impression waxes. Alginate, agar, polysulfides, additional and condensation silicones, polyethylene. These are elastic. Based on compression of underlying tissues, they are divided into mucostatic and mucocompressive. The mucostatic, impression plaster and glide body elastomers. the mucocompressive, the impression compound, and putative elastomers. Irreversible hydrocolloid. Irreversible hydrocolloid is not sufficiently accurate for cast restorations. Each material has advantages and disadvantages, and none is entirely free of shortcomings. However, they all share one important characteristic. When handled correctly, they can produce casts of sufficient accuracy and surface detail for the fabrication of clinically acceptable fixed prostheses. Nevertheless, there are reasons for selecting one material over another. If it becomes necessary to store the impression before a cast is made, the polythias and additional silicones are preferable because they exhibit sufficient long-term dimensional stability. The other materials, particularly the reversible hydrocolloids, must be powdered immediately. If the impression is to be powdered in epoxy or electroplated, reversible hydrocolloid should not be selected because it is compatible only with D-stone. Alginate. Alginate is an elastic, irreversible hydrocolloid impression material. Irreversible hydrocolloid impression form an inseparable part of indirect restorations. Alginate is one of the most frequently used dental materials, and alginate impression is a simple, cost-effective, and indispensable part of dental practice. Yet very few people can make alginate impressions just right the first time. For many years, alginate impression material has been a staple of most dental practices. They form a major bulk of our clinical practice even today. Therefore, it becomes mandatory to understand the material and follow certain fundamental guidelines for flawless, predictable impressions and hence avoid repeat impression or restorations. Irreversible hydrocolloid can be used in preliminary impressions, provisional crown and bridge impressions, study models, opposing dentition impressions. Alginate are used for impressions in orthodontic models, sport mouth guards, and bleaching trays, and more. Alginate impressions can be used as final impressions for indirect restorations when the preparation margins are chamfer. Chemistry and setting. The powder contains sodium alginate, calcium sulfate, the sodium phosphate, diatomaceous earth, zinc oxide, and potassium titanium fluoride. While mixing the powder with water, a sol is formed. A chemical reaction takes place and a gel is formed. Here, sodium alginate reacts with calcium sulfate, resulting in sodium sulfate and calcium alginate. This reaction occurs too quickly, often during mixing or loading of the impression tray. Hence, it is slowed down by the addition of trisodium phosphate to the powder. Trisodium phosphate reacts with calcium sulfate to produce calcium phosphate, preventing calcium sulfate from reacting with sodium alginate to form a gel. This second reaction occurs in preference to the first reaction until the trisodium phosphate is used up, and then alginate sets as a gel. There is a well-defined working time during which there is no viscosity change. Alginate materials possess the qualities of good surface detail and fast reaction at higher temperatures. They are elastic enough to be drawn over the undercuts, but tear over deep undercuts and are not dimensionally stable on restoring due to evaporation. Alginates are non-toxic and non-irritant. Alginate powder is unstable on storage in the presence of moisture or in warm temperatures. Alginate impressions materials are easy to use, less expensive, with quick setting time. The setting time can be controlled with the temperature of water used. They are mildly flavored. Their disadvantages include less accurate reproduction of details as compared with elastomeric impression materials. poor dimensional stability, and that they are messy to work with. The most popular form of alginate is supplied as a powder, which is mixed with water. Many alginates are supplied with a reaction indicator that changes column impression when the material is set, and presently dustless alginates are preferred. Powder may be available in bulk form, in containers, or in individual sealed pouches. Paste type of alginate is also available. Paste form is available in two viscosities, clay and syringe viscosities. The paste type material has a shorter gelation time than the powder type material. The best surface quality can be obtained with the paste type material. Studies suggest that a paste type material would better meet the requirements of an alginate impression material. Selection of impression tray. As is the case with all impression materials, it is important to select the correct tray for the dental arch. The stock trays to be selected for alginate should be perforated. Alginate adhesives can be used apart from perforations for retention of alginate to the impression tray. Use of alginate adhesives overcomes displacement forces during withdrawal of the impression from the mouth. Alginate adhesives are available as paint on or spray on. The use of brush can result in cross-infection of patients. After application of alginate adhesive, it is allowed to dry for 5 minutes. More frequently, the stock trays would require some customization in the form of tray modification. Modifications can be done with wax, trace and stick impression compound, or heavy-bodied silicone, depending on the operator's convenience. Stick compound is preferable as wax is non-rigid. Impression trays and their modifications should be rigid. Modified impression tray must be placed in the mouth and muscle trimmed. Before making an impression, the dental arch to be impressed should be examined carefully. If there are any existing fixed partial dentures, the pontics requires to be blocked out with wax so that the impression does not tear in these regions. If the patient's palatal wall, trace and stick compound can be used in the center of the maxillary tray to reduce the bulk of alginate impression material. In case teeth are missing, in one posterior quadrant, modeling compound is softened in a water bath and placed in the tray to make an impression of the edentulous areas. The imprints of the teeth should be cut out with a sharp knife so that the compound has definite stops against the maxillary tubercle. Is trimmed so that from 3 to 5 millimeters of clearance between compound and mucosa exists, except in posterior palatal seal area. This compound modification of the impression tray should be firmly adhering to the tray. If not, wax paddle is heated to merge with the tray borders carefully. The compound surface softened with a flame and a ball of cotton is pressed into the surface for a few seconds, leaving short cotton fibers embedded. The cotton fibers provide retention for alginate material. Impression trays placed in cold water to harden the compound. Mixing and loading alginate. Commonly used alginate materials are supplied in containers. A scoop is provided for measuring the powder of the alginate. In such cases, distilled or demineralized water can be used. Mixing is initiated by adding measured quantity of water to clean flexible rubber bowl. This is followed by the addition of correctly proportioned powder. Colder water can be used if longer working time is desired. Setting time should be controlled by varying water temperature and not the consistency of mix. Mixing should be rapid with a wide-bladed spatula. The resultant mix should be creamy in consistency, but must not drip off the spatula when lifted from the bowl. Mechanical mixing of alginating devices such as the alginator second or the combination unit ensures that the alginate mix is the same each time they are mixed. Mixing time is 60 seconds for hand spatulation and 15 seconds for mechanical. The required amount of material is loaded onto the tray. The tray must be filled with the impression material up to tray borders, and any excess unsupported material overfill tray at the periphery must be removed with the mixing spatula. The surface of the alginate is smooth with a wet, gloved finger. Prepare the mouth before impression. For dentate cases, occlusal surface of teeth should be blown off with an air syringe to remove debris and saliva. In order to minimize air blows, at the same time the teeth should not be left to dry completely, since alginate material sticks to dried teeth as the thin film overlying the teeth is removed. When the surfaces are dry, the alginate radicals in the impression material form chemical bonds with heteroexcipited crystal of the enamel. Hence, alginate tears upon removal. Having the patient rinse with water and mouthwash mixture will eliminate mucin and lower the surface tension, thereby eliminating air bubbles. If repetitive impressions are made with the alginate, the film over the teeth is lost and getting a satisfactory impression is prevented. While repeating impressions, the patient must be asked to rinse the mouth to rehydrate and produce a new film over the teeth for accurate impressions. Impression making. The mixed alginate should be rubbed onto the occlusal surface with a gloved finger to fill the occlusal grooves, allowing accurate reproduction of the occlusal tooth anatomy. Some alginate must be placed in the pencil vault. Impression tray is positioned in the mouth by retracting the patient's lips on one side with the mouth mirror or gloved finger, and on the other side by rotating the tray into the mouth. The tray has to be centered in position in the mouth, and with light pressure, impression is held in place. The soft tissues, especially the labial finger, should be released and manipulated for the alginate to flow into the solder and record the details. When the tray is seated, pressure should be released immediately and the tray should be held lightly in place to prevent unseating. It is imperative to release pressure as soon as the tray is seated. Alginate materials start setting from the tooth surface to the impression tray. Pressure will cause impression to set under strain. On removing the impression from mouth, these strains will be released, causing distortion and an inaccurate cast. Moving the impression tray during rejuvenation will incorporate similar strains. Removal and inspection of impression. Once set, the impression has to be removed with a firm, quick snap. The impression should not be rocked or twisted before or during removal of the impression. This is to minimize the time for which the set material is distorted as it moves over the teeth. The seal between tissues and the impression may have to be removed before removal of maxillary impressions, by gently pushing with the gloved finger or by using a syringe into the buccal sulcus. During removal of maxillary impression, the operator's index fingers of both hands should be in the buccal sulcus to break the seal, while thumb holds a tray handle and the other fingers support the impression tray. Upon removal of the impression from the mouth, impression is inspected for defects under good lighting before it is rinsed. The impression should be rinsed with cold water to remove any saliva or blood. Most patients have thin, serous saliva. This type of saliva can be removed by holding the impression under gently running cool tap water. But thick, ropey saliva is difficult to remove. A thin layer of dental stone powder can be sprinkled onto the surface of the impression. The stone adheres to saliva and acts as a disclosing agent. When impression is placed under running tap water, the saliva will be seen and can be removed by light brushing with wet camel's hair brush. The impression should then be covered in a damp coarse napkin to prevent syneresis. It is generally not recommended to place in water, which would cause impatient expansion. Storage and disinfection. Said alginate undergoes imbibition and syneresis if left in a normal clinical environment. The time before caspouring is critical. After being removed from the mouth, alginate impressions should be washed with water spray, disinfected by means of the practitioner's choice of disinfection procedures, and dried until the shine just disappears. The impression has to be covered with damp hose and left in a Ziploc plastic bag until the cast is powered. Cast powering must be delayed for 10 minutes, as the elastic recovery of alginate impression material is slow. Distortion can be a problem if disinfection guidelines are not strictly adhered to. Hydrocolloids are hydrophilic in nature, hence, they swell if immersed in water or disinfectant. Disinfectant sprays are used for alginate impressions, but they do result in air bubbles in the cast. Immersion disinfects like 1% sodium hypochlorite or 2% glutaraldehyde can result in changes of 0.1%, and hence the quality of the impression surface may not be impaired if the recommended period of the time is strictly followed. Test fabrication. Alginate impressions should be powered using vacuum mixed stone hand vibrator. A thick mix can trap air bubbles. The stone should be allowed to set in trays with the teeth down. If tray is turned upside down onto a base of stone, there would be a tendency for water to rise to the highest point, cusp tips. This can result in faulty, very soft cusps on the model. Inventing the tray may also bend alginate away from tray if excess materials has not been trimmed away prior to pouring. Cast has to be removed immediately after adequate set. Otherwise, the model would have a moth-eaten appearance. Reversible hydrocolloid. Reversible hydrocolloid, also called a hydrocolloid or simply hydrocolloid, was originally derived as a natural product of kelp. However, the material currently available is considerably different. If powered immediately, reversible hydrocolloid produces casts of excellent dimensional accuracy and acceptable surface detail. At elevated temperatures, it changed from a gel to a sol. This change is reversible. That is, as the material cools, the viscous fluid sol is converted to an elastic gel. Agar changed from gel to sol at 99 degree of Celsius, but remains a sol as low as 50 degrees of Celsius, forming a gel only slightly above body temperature. These unique characteristics are very favorable for its use as an impression material. Reversible hydrocolloid is supplied in a range of viscosities. In general, a heavy-bodied tray material is used with a less viscous syringe material. The required temperature changes are affected with a special conditioning unit and water-cool impression trays. Reversible hydrocolloids' lack of dimensional stability results primarily from the ease with which water can be released from or absorbed by the material, syneresis and imbibition. The accuracy of a reversible hydrocolloid impression is improved if the material has as much bulk as possible, low surface area or volume ratio. This contrasts with the elastomeric impression materials, whose accuracy is improved by minimizing bulk, polysulfide, and condensation silicon. Because stresses produced during removal area reduced. Therefore, an additional advantage of reversible hydrocolloid is that a custom impression tray is not required. Polysulfide polymer. The polysulfides, commonly, although erroneously, known as rubber bases, were introduced in the early to middle 1950s. They were received enthusiastically by dentists because they had better dimensional stability and shear strength than did hydrocolloid. Nevertheless, they should be powered as soon as possible after impression making. Delays of more than an hour result in clinically significant dimensional change. There is a slight contraction of polysulfide during polymerization, but the effects can be minimized with a custom impression tray to reduce the bulk of the material. In general, a double mix technique is used with a heavy-bodied tray material and less viscous orange material. These polymerize simultaneously, forming a chemical bond of adequate strength. The high tear resistance and enhanced elastic properties of polysulfide facilitate impression, making in sulcal areas and pinholes, and it has improved dimensional stability over hydrocolloid. Although it is the least expensive elastomer, it is not well liked by patients because of its unpleasant sulfide odor and low setting time in the mouth, about 10 minutes. Furthermore, high humidity and temperature dramatically reduce its working time, which may be so short that polymerization begins before it is inserted in the mouth, which results in severe distortion. Condensation silicon. Some of polysulfide's disadvantages have been overcome by condensation silicon, which is essentially odorless and can be pigmented to virtually any shade. Unfortunately, its dimensional stability is less than that of polysulfide, but greater than that of reversible hydrocolloid. An advantage of the silicone is its relatively short setting time in the mouth, about 6 to 8 minutes. As a result, patients tend to prefer condensation silicone over polysulfide. In addition, condensation silicone is also less affected by high operating room temperatures and humidity. Silicone's main disadvantage is its poor wetting characteristics, which stems from its being extremely hydrophobic. For this reason, it is used in commercial sprays that protect automobile electrical systems from moisture. In this context, the prepared teeth and gingival silting must be completely free of moisture so that a defect-free impression is possible. Pouring without trapping air bubbles is also more difficult than with other impression materials, and a surfactant may be needed. Silicone impression material is available in a variety of viscosities. One technique involves a heavily filled putty material that is used to customize a stock impression tray in the mouth, generally with a polyethylene spacer. The spacer allows room for a thin wash of light-bodied material, which makes the impression. The technique requires considerable care in sitting, however, to prevent strain in the setup putty. And if this happens, the impression rebounds when removed from the mouth, which results in dies that are too small. Care is also needed to avoid contaminating the putty surface with the saliva, which prevents the wash impression from adhering properly. Silicon and polysulfide have a dimensional instability that results from their mode of polymerization. Both are condensation polymers, which, as a byproduct of their polymerization reactions, give off alcohol and water, respectively. As a result, evaporation from the set material causes dimensional contraction in both. Polyether. Polyether impression material developed in Germany in the middle of 1916s has a polymerization mechanism unlike those of the other elastomers. No volatile byproduct is formed, which results in axial dimensional stability. In addition, its polymerization shrinkage is unusually low in comparison with most room temperature cured polymer systems. However, its thermal expansion is greater than that of polysulfide. With the high dimensional stability of polyether, accurate casts can be produced when the material is sparred more than a day after the impression has been made. This is especially useful when powering the impression immediately is impossible or inconvenient. Another advantage of polyether is short setting time in the mouth, about 5 minutes, which is less than half the time required of polysulfide. For these reasons, polyether is used by many fractioners. However, polyether has certain disadvantages. The stiffness of the set material is one such disadvantage which causes problems when a stone cast is separated from the impression. Thin and single teeth, in particular, are liable to break unless the fractioner uses great care. Polyether is stable only if stored dry, because it absorbs moisture and undergoes significant dimensional change. Polyether's relatively short working time may limit the number of prepared teeth that can be reliably captured in a single impression. Isolated cases of allergic hypersensitivity to polyether elastomer have been reported, manifested as sudden onset of burning, itching, and general oral discomfort. Therefore, the allergic patient's record should carry a warning against the polyether's future use, and an alternative elastomer should be chosen. Improvements in these materials have reportedly reduced this problem. What about additional silicon? Additional silicon has introduced as a dental impression material in the 1917s, also known as polyvinylsiloxane. Polysiloxane is the generic chemical expression for silicon resins. It is similar in many respects to condensation silicon, except that it has much greater dimensional stability, equivalent to polyether polymer, and its working time is more affected by temperature. The set material is less rigid than polyether but stiffer than polysulfide. As with the other materials previously described, adverse soft tissue responses have been reported. One disadvantage of some of these materials is that set inhibition can occur with selected latex gloves. Tithiocarbamides, which are used in glove manufacturing as either vulcanizing agents or accelerators, have been implicated as causative agents. Glove exposure to alcohol has been shown to accelerate setting inhibition for selected impression material, latex glove combinations. The problem is most apparent if a hand-mixed putty is used, but problems can occur if the tissues are touched with gloved hands immediately before impression placement. It has also been shown that sulfide and sulfide fluoride can be transferred from latex gloves to retraction cord, which enables the transfer of these non-inhibiting agents to cellular tissues. When additional silicones are used, gloves that do not Gloves that do not interfere with setting should be selected. Like condensation silicone, addition silicones are hydrophobic. Some formulations contain surfactants, which give them hydrophilic properties, imparting wettability similar to that of the polyethers. However, these products also expand like polyether when in contact with moisture. Addition silicone is generally used as two-viscosity system, although many phase formulations are also available. It is easier to trap bubbles when the monophase formulation is used. Manufacturer recommendations should be followed when a cast is being poured, and powering should be delayed with some of the earlier products. If this is not done, a generalized porosity of the cast surface caused by gas from the impression material will develop. Newer products contain scavengers that prevent the escape of gas at the polymer cast interface. Additional silicone that contains scavenger material can be poured immediately. Here you can see the scanner electron microscope finding of gingival retraction board contaminated by latex glove contact. Arrows indicate particles on surfaces and within fibers of gingival retraction cord. Electron probe microanalysis of gingival retraction cord contaminated by latex glove contact. So red color indicates sulfur element. Here you can see with black arrows on the right side. Impression trace. The choice of impression material influences trace selection. Reversible hydrocolloids require special water-cooled trays, whereas irreversible hydrocolloid and melastomeric impressions for uncomplicated fixed orthodontic procedures are made with prefabricated impression trays. To reduce associated distortion in the variables associated with the use of such trays, they must have adequate rigidity, and tray design should provide for control of impression material thickness. Retention is provided by perforations, rim locks, and drawer adhesives. Custom trays are fabricated for each patient individually through the use of diagnostic casts and offer a number of advantages over prefabricated stock trays. Adhesives should be applied sufficiently in advance to allow through diring, although they may remain slightly thick to touch. Because evaporation of its volatile solvent is time dependent, it is preferable to apply the adhesive in the thin layer. Spray adhesives have been shown to result in significantly less retention of polyvinyl siloxane impression materials to both outer polymerizing and photopolymerizing tray materials than do paint-on adhesives. Here you can see the first step of the custom tray fabrication in the lower picture. A custom tray improves the accuracy of an elastomeric impression by limiting the volume of the material, thus reducing two sources of error: stresses during removal and thermal contraction. Although reducing the bulk of an elastomeric impression material increases its accuracy, the opposite is true for reversible hydrocolloid impressions. In hydrocolloid impressions, dimensional change is caused by water loss or gain from the surface of the impression. A bulky hydrocolloid impression has a lower surface area of volume ratio and is therefore less subject to dimensional change. Custom trays can be made from outer polymerizing acryl resin, thermoplastic resin, or photopolymerized resins. Thermoplastic materials can be softened in a water bath and adapted either manually or with a vacuum former with a heating element. The accuracy of impressions made with a thermoplastic tray material or light polymerized material is comparable with that of impressions made with an outer polymerized resin. Light polymerized materials are convenient because the storage period is not needed for the completion of the polymerization. In addition, the resin is less susceptible to distortion in moisture, and the impression is thus suitable for the electroformed D technique. Custom tray fabrication. With any system tray rigidity, it is important because even slight flexing of the tray leads to a distorted impression. This is particularly frustrating because the errors are usually undetectable until the practitioner attempts to see the restoration. For this reason, thin disposable plastic trays are unacceptable. Resin thickness of 2 to 3 millimeters are needed for adequate rigidity. Clearance between the tray and the teeth should also be from 2 to 3 millimeters. However, greater clearance is necessary for the more rigid polyethylene materials. Step-by-step procedure with ultrapolymerizing resin. Using a pencil, mark the border of the tray and the diagnostic cast approximately 5 millimeters apically to the crest of the free gingiva, less for the more rigid impression materials. Allow for muscle and foramen attachments. Maxillary trays do not always necessitate covering the entire palate, although this may be desirable if a removable appliance is planned after completion of the fixed prosthesis. Under no circumstances should the posterior border extend further than the demarcation between hard and soft palates. Adaptable works or other suitable spacer to the diagnostic cast. Two layers of the base plate works result in a combined thickness of approximately 2.5 millimeters. The sheet should be matched with a thickness gauge because wax thickness vary. Soften the wax by carefully heating it over a Bunsen burner or in hot water. Overheating may melt it and produce an undesirable thin spot. Only light pressure should be applied. After the second sheet of wax has been applied, trim it back until the pencil line is just visible. An alternative technique involves repeated dipping of the cast in molten wax. The cast is thoroughly wetted and then dipped 3 or 4 times to obtain a sufficient and uniform wax thickness, about 2 or 3 millimeters. This creates the space needed to the impression material. These stops are needed in the tray to maintain even space for the impression material in the oral cavity. These are placed on non-functional cusps of teeth that are not be prepared buccal cusps of the maxillary, lingual cusps of the mandibular. If all teeth are removed, a large soft tissue stop can be placed on the crest of the alveolar ridge or in the center of the hard palate. Stops are made by removing wax at an angle of 45 degrees to the occlusal surfaces of 3 teeth that have a tripodal arrangement in the arch. This lends stability to the tray, and the 45-degree slope helps center to the tray during insertion. So, apply a layer of tin foil over the wax, which may melt from the polymerization heat of the material to prevent it from contaminating the inside of the tray. Mix auto-polymerizing acrylic resin according to the manufacturer's recommendations. The use of vinyl gloves is recommended to prevent the development of sensitivity to the monomer. After the resin is mixed, set it aside until it is doubly with the consistency of butter. A template or a wooden slab and roller may help obtain a consistent thickness, although with practice the resin can be thinned out accurately by hand. Care must be taken not to stretch the material when manipulating it. Thin areas in the resin may lead to a flexible tray and produce distortions. Gently adapt the resin to the cast. A handle made from the excess resin can be attached at this time. If working time is unavailable, it can also be attached later with a separate second mix of acrylic resin. Focal reeds, which are helpful with the impression removal, can also be added. After the material has polymerized, remove it from the cast and trim it with an acrylic trimming burr where the indentation made by the wax ledge is visible. All rough edges should be rounded to prevent soft tissue trauma. If necessary, fill defects in the stops with additional resin, wetting the set tray material with monomer to ensure a good bond. To prevent the material from lifting up, some pressure should be maintained during this phase. Here you can see drawing of a cross-section through a mandibular custom tray. Stops have been placed on the non-functional cusps so that distortion does not interfere with the intercuspal relationship. The 45-degree slope helps to center the tray during seating. You can see with arrows. Space exists for the impression material. Step-by-step procedure with photopolymerized resin. Remove photopolymerized tray material sheets from their light-proof packaging and adapt them to the relieved cast. Adapt small pieces in the areas of the stops first to make sure they get filled completely. 2 sheets are needed to make each tray and should be cut as shown. Carefully adapt the large piece of material to the cast, being careful not to extend by material beyond the script borders. Use a scalpel blade to trim the excess material away from the cast. It may help to roll the edge of the material back onto itself and the borders so that it is not too thin in these areas for trimming. Adapt the material with fingers, gloves, until the pieces blend together and no seams are visible. Do not press hard on the material, will be deformed and thinned. This wicks the tray. Shape and attach a handle by molding excess material. Blend into the tray material. A paper clip can be used to support the handle material by elapping the material around it. Position the cast in the curing unit for approximately 2 minutes. Remove from the curing unit, separate the tray from the cast, and remove the softened wax spacer and the aluminum barrier. Paint the tray with the air bear coating provided by the manufacturer. Return the cast to the curing unit and cure in accordance with the time recommended by the manufacturer. Remove the tray and scrub it clean under running water. Clean the tray and trim. As for the outer polymerizing resin tray, add additional resin if you need it. Evaluation. The completed custom tray needs to be rigid with a consistent thickness of 2 or 3 millimeters. It should extend about 3 to 5 millimeters, cervical to the gingival margins, and should be shaped to allow muscle attachments. It should be stable on the cast with stops that can maintain impression thickness of 2 or 3 millimeters. The tray must be smooth with no sharp edges. Finally, the handle should be sturdy and shaped to fit between the patient's lips. To avoid distortion from continued polymerization of the resin, the tray should be made at least 9 hours before its use. When a tray is needed more urgently, it can be placed in boiling water for 5 minutes and allowed to cool to room temperature. A light polymerized tray can also be made. Impression making with elastomeric materials. Evaluate the custom tray in the patient's mouth to verify its fit. Correct the tray as needed. Apply tray adhesive to extend a few millimeters onto the external surface of the tray. Isolate the abutment teeth and place the gingival displacement cord in the sulcus. On separate pads, one for the tray and one for the syringe material, disperse equal amounts of base and accelerator. When mixing polysulfide polymers, pick up the brown catalyst first rather than the white base material, because the base sticks to the spatula and makes it virtually impossible to incorporate all the catalyst. Blend the two pastes thoroughly. Initially, the spatula is kept somewhat vertical during mixing. This position is changed gradually to be more horizontal as the two pastes become better incorporated. At this time, the spatula is swept on a clean paper towel. Mixing continues for another 10 seconds to ensure that the material is homogeneous. Load the syringe. This can be done by holding the barrel vertically, pushing it through the mix, and then angling and sliding the sideways over the mixing pad. The syringe can also be loaded from the other end by picking up the mixing sheet, forming a funnel and expressing the material into the breech of the syringe. Remove the displacement cord and gently dry the preparation with compressed air. Place the tip of the syringe nozzle so that it touches the margins and inject the material slowly. The tip should be inserted into the most distal embouchure first. This prevents the material from flowing down over the preparation and trapping air bubbles. The tip is moved so that it follows the material rather than traveling ahead of it. When all the margins and actual surfaces have been covered, the material is air-blown into a thin layer. This improves the accuracy of the impression because the light-bodied material has greater polymerization shrinkage than does the tray material. Express additional material to any dentulous spaces, lingual cavities of the anterior teeth, which are important for guidance, and occlusal surface of the posterior teeth, which are important for obtaining accurate articulation. Seat the tray. It must remain immobile while the material undergoes polymerization, 6 to 12 minutes, depending on the material. Otherwise, strains form in the elastomer, which can cause distortion of the impression when it's removed. The manufacturer's recommendation for maximum working time and minimum setting time should be followed. It is difficult to judge clinically when elastomers start to develop elasticity. Any delay in seating the tray results in a distorted impression. It is tempting to remove the impression too soon because the patient may find it uncomfortable. However, premature impression removal is a common cause of impression distortions. What about single mix technique? The same steps are performed for the single mix techniques as for the heavy body light body technique. However, as the name indicates, only one mix is used to load the syringe and fill the tray. Most single mix materials tend to produce a slightly higher viscosity mixed with a slightly shorter working time. Auto-mix technique. Most manufacturers offer impression material in pre-packaged cartridges with a disposable mixing tip attached. The cartridge is inserted into a caulking gun-like device, and the base and catalyst are extruded into the mixing tip, in which mixing occurs as they progress to the end of the tube. The homogeneously incorporated material can be directly placed on the prepared tooth and impression tray. One of this system's advantages is the elimination of hand mixing on pads. The elimination of this variable has been shown to produce fewer voids of the impression. Following the manufacturer's directions and bleeding the cartridge before inserting the tip are crucial to ensure that possible residue of partially polymerized material is removed from the cartridge openings, which might prevent equal amounts of base and catalyst from being dispensed. Auto-mix material is not available for the polysulfide polymers because these materials are too quickly for proper mixing with existing cartridge tips. You can see the machine mixing technique. An alternative method for improving impression mixing is to use a machine mixer. This system is convenient and produces void-free impressions. Reversible hydrocolloid. Reversible hydrocolloid impression material requires a special conditioning unit, which is made up of 3 thermostatically controlled water baths and liquefaction bath for the heavy-bodied tray material and the light-bodied syringe material, a storage bath about 65 Celsius for maintaining liquid filled materials until needed. A tempering bath about 40 degrees Celsius for reducing the temperature of the heavy body tray material enough to avoid tissue damage. Step-by-step procedure. Select the correct size water-cooled impression tray. For maximum accuracy, use a large size as can be comfortably accommodated by the patient. Place prefabricated stops across the posterior of the tray to prevent overseating and to provide additional retention. For adequate access, displace the gingival tissues. Fill the impression tray with heavy-bodied material from the storage bath. Add wash material to the surface of the hydrocolloid tray material in the area of the preparation and one adjacent tooth. Submerge the tray in a tempering bath. Carefully remove the cord from the sulcus and flood the sulcus with warm water. Remove the impression tray from the tempering bath and seat the tray into the patient's mouth. After seating, initiate and maintain the flow of room temperature water through the tray. Hold the tray firmly in the patient's mouth while the impression material is chilling. Remove the tray with a rapid motion. Wash it with room temperature water, disinfect it, and evaluate it for accuracy. Potassium sulfate can be used as a dipping solution for improved stone characteristics. After the impression is judged to be acceptable, pour immediately in type 4 or type 5 stone. If delay is inevitable, the impression can be immersed in a special oil-based solution. Closed mouth impression technique. The closed mouth impression technique, also called the dual arch triple tray technique, is popular for making impressions for single units and less expensive restorations made to conform to the existing occlusion. The impression is made at maximum interexpansion with a high viscosity polyurethane or polyvinyl silicone impression material supported by a thin mesh in a frame. The impression includes the prepared tooth, the adjacent teeth, and the opposing teeth, and records the maximum interexpansion relationship, hence the name triple tray. Because the impression is made at the occlusal vertical dimension, the technique facilitates making a highly accurate impression and occlusal record. However, the laboratory stage must be performed very carefully, and so eccentric relationships are recorded. These need to be evaluated and adjusted at restoration delivery. A step-by-step procedure. Select and evaluate a closed mouth tray. Make sure the patient can close easily into maximal interexpansion without interference with the tray. Apply adhesive to tray works. Load both sides of the closed mouth tray with a high viscosity elastomeric compression material. Concurrently, remove cord and using a syringe, apply impression material into crucial areas. Place the loaded closed mouth tray into position and have the patient close properly. Check the contralateral side to verify maximum interexpansion. Remove the polymerized impression, helping the patient open the mouth by applying pressure to the set material or tray border on the non-prepared side. Pin retained restorations. Elastomeric impression material are strong enough to reproduce a pinhole without tearing. However, to avoid bubbles, they must be introduced carefully into the pinhole with a lentilla or cement tube. With reversible hydrocolloid, a special nylon bristle must be used for the impression. Step-by-step procedure. Apply a separating medium to the pinholes and isolate and display the tissue in the conventional manner. After mixing the light-bodied impression material, set aside a small amount for placement into the pinholes. Fill the tube and squeeze a small amount of material into each pinhole. Make sure that no air is trapped into the base of the pinhole. Insert an explorer into the material, remove and repeat the application. Be sure that the slow speed handpiece is rotating clockwise before picking up a small quantity of impression material with the lentilla. Deliver the material in a spiraling manner into the pinholes, rotating the instrument slowly while moving the lentilla along the sides of the pinhole. Increase the speed of the lentilla while backing it out to prevent the material from being pulled out. When making a reversible hydrocolloid impression of a pin-retained restoration, use plastic bristles to register the pinholes. The bristles can be modified as necessary with a sharp scalpel to eliminate any inaccuracy relating to fit. Their lengths should be adjusted so that they do not contact the impression tray. A bristle should extend 2 mm above the opening of the pinhole. Apply a separating medium to the pinhole before placing the bristle and completing the impression. What about disinfection? When they are removed from the patient's mouth, it must be assumed that all impression materials have been in contact with the body fluids. They should be disinfected according to the recommended procedures for the material being used. After being removed from the patient's mouth, the impression is immediately rinsed with tap water and dried with an air syringe. Suitable chemicals should be used, such as glutaraldehyde solutions or iodophor sprays. Some are perfectly acceptable for one material, but unsuitable for others. Because of its tendency to distort and absorb moisture, polyethers or hydrophilic addition silicone impression materials should be sprayed and stored in a plastic bag rather than submerged and soaked in a glutaraldehyde solution. Disinfection is an essential step for preventing cross-infection and exposure of laboratory personnel. If it's performed properly, disinfection does not affect the accuracy of surface reproduction of the elastomer. Evaluation. After disinfection, the completed impression is inspected carefully before the definitive cast is made. An elastomeric impression should be dried before it is evaluated. The following points are then considered. Has the material been properly mixed? An impression that contains visible streaks or base or catalyst material should be rejected. Is there an area where the custom tray shows through? This must be identified and its potential effect on the quality of the impression assessed. Common error is rotation and the resulting inaccurate seating of the tray. This can result in the tray non-tacting several teeth and an uneven thickness of impression material. Normally this occurs only at the tray stops, but when it touches a critical area, the impression must be discarded and a new one made. However, if a thin spot is not near the prepared teeth, it can sometimes be allowed to remain. Are there any voids, folds, or creases? This should have been avoided by careful technique. However, the impression may still be acceptable when a small defect is present in a non-critical area, away from the margin of a prepared tooth. Careful judgment must be exercised. Is there an even Uninterrupted extension of impression material beyond the margins of the preparate teeth. This is essential if restorations with well-fitting margins and correct contours are to be made. Has the impression material separated from the tray? This is a common cause of distorted impressions and results from improper application and/or inadequate drying of the adhesive. Displacement of gingival tissues. Tissue displacement is commonly needed to obtain adequate access to the prepared tooth to expose all necessary surfaces, both prepared and not prepared. This can be achieved by mechanical, chemical, or surgical means. Mechanical displacement is most effectively achieved by placement of a cord. Alternatively, paste systems can be used, often in conjunction with directed pressure. Chemicals such as aluminium sulfate or epinephrine cause localized foil on one side. The paper side is placed against the dried buccal tissue and adheres to it. In addition, two cotton rolls should be placed in the maxillary and mandibular vesicles to control saliva and displace the cheek laterally. Displacement cord. Some enlargement of the gingival sulcus can be obtained by placing a non-impregnated cord and leaving it in place for a sufficient length of time. The cord is pushed into the sulcus and mechanically stretched the circumferential periodontal fibers. Placement is often easier if a braided cord or a knitted cord is used. However, larger sizes of braided cord should be avoided because they have a tendency to double up and can become too thick for traumatic intrasulcular placement. In areas where very narrow sulci preclude placement of the smaller sizes of twisted or braided cord, wool-like cords that can be flattened are preferable for initial displacement of tissue. Better sulcus enlargement can be achieved with a chemically impregnated cord or by dipping the cord in an astringent. These materials contain aluminium or iron salts and cause a transient ischemia, shrinking the gingival tissue. Cords with metal filament reinforcement have been developed to help maintain their intrasulcular position. Even so, the sulcus close quickly, less than 30 seconds, after the cord is removed. Therefore, their impression must be taken immediately. In addition, adherents help control seepage of gingival fluid. Aluminium chloride and ferric sulfate are suitable because they cause minimal tissue damage. As an alternative, a sympathomimetic amine containing eye wash or nasal decongestant are effective. Many of the chemicals used for their astringent effect are stable only at narrow ranges of low pH levels. The low pH levels have raised concern about the effect of acidic solutions on tooth structure and perhaps of more importance on the small layer. Contact between the astringent and the prepared tooth surfaces must be minimized in the small layer is to be maintained. A non-acidic hemostatic agent can be used as an alternative. Several displacement cords pre-impregnated with epinephrine are available commercially. Epinephrine should be used with caution because it may cause tachycardia, particularly if it's placed on lacerated tissue. Dosage control is also a potential problem. In one study, clinicians were unable to detect any advantages of using gingival retraction cords that were impregnated with epinephrine. On the picture, you can see the dentin surface prepared with a high-speed fine grit diamond. On the base, after exposure to 15% film solution for 30 seconds, the small layer is largely removed, but many dentinal tubules are still occluded. After 2 minutes of exposure on the picture C, Now the small layer is totally removed, although the peritubular dentine appears to be largely intact. The picture D is that after 5 minutes of exposure. Now the dentine is etched and peritubular dentine has been largely removed. Step-by-step procedure. Isolate the preparate teeth with cotton rolls. Place saliva evacuators as required and dry the field with air. Cut a length of cord sufficient to encircle the tooth. Do not excessively desiccate the tooth because this may lead to post-operative sensitivity. Dip the cord in astringent solution and squeeze out the excess with a gauze square. An impregnated cord can be placed dry but should be moistened in situ to prevent the thin circular epithelium from sticking to it and tearing when it is removed. If a non-braided cord is used, twist it tightly for easier placement. Loop the cord around the tooth and gently push it into the sulcus with a suitable instrument. It is best to start the interproximal area because the cord can be placed more easily there than facially or lingually. The instrument should be angled toward the tooth so the cord is pushed direct into the sulcus. It should also be angled slightly toward any cord already pecked. Otherwise, that might be displaced. A second instrument may aid placement. Tissue must be displaced gently but with sufficient firmness to place the cord just apical to the margin. Overpacking should be avoided because it could cause tearing of the gingival attachment, which leads to irreversible recession. Repeated use of displacement cord in the sulcus also should be avoided because this can cause gingival recession. What about evaluation? Difficulty with tissue displacement is often the result of gingival inflammation. The inflamed and swollen tissue bleeds easily, preventing access by the impression material. Initial assessment of cord placement can be a useful indicator of the amount of displacement accomplished. When looking at the tooth preparation from the occlusal aspect, the clinician should be able to see the preparation margin circumferentially and the uninterrupted cord with no soft tissue folded over it in contact with the tooth. If there is any doubt, assessing displacement by removing the cord is a good idea. The entire preparation margin should be clearly visible and remain directly accessible for about a minute. Typically, if the result is acceptable, a second cord is quickly inserted to maintain the displacement while the impression material is mixed. If the sulcus enlargement is not favorable, the tissue health should be passed, particularly if adequate displacement cannot be obtained by repeating the previous steps. Hemorrhage control with an infuser syringe. Fill the syringe with pyric sulfate solution and attach the infuser tip. This hollow metal tip contains a cotton filament to help control flow on the medicament. Rub the tip back and forth for approximately 30 seconds over the hemorrhaging area while slowly replenishing the solution by continuous injection. Irrigate the area with an air-water syringe and gently dry the tissues with air. Inspect to determine the degree to which bleeding has diminished. Repeat several times if necessary and place a displacement cord. Before cord removal, slightly moisten the cord with water to minimize the risk of dislodgement of blood clots and renewed hemorrhage. Gently dry the tissues and proceed with impression making. Displacement paste. Some dentists advocate displacement paste as an alternative to cord. The product consists of an aluminum fluoride containing paste that is injected into the dried sulcus with a special delivery gun. Advantages of the system include good hemostasis without discomfort than traditional cord. However, less tissue displacement is achieved than with cord, which may make the trimming more problematic. Improved displacement may be achieved if the paste is directed into the sulcus by applying pressure with a hollow cotton roll. An electrosurgery unit may be used for minor tissue removal before impression making. In one technique, the inner epithelial lining of the gingival sulcus is removed, thus improving access of a subgingival crown margin and effectively contouring post-surgical hemorrhage, provided that the tissue are not inflamed. Unfortunately, there is a potential for gingival tissue recession after treatment. Electrosurgery unit works by passage of a high-frequency current from 1 to 5 million Hz through the tissue from a large electrode to small one. At the small electrode, the current induces rapid localized polarity change that causes cell breakdown, cutting. For restorative procedures, as unmodulated alternating current is recommended because it minimizes damage to deeper tissues. The following facts should be considered before electrosurgery is attempted. It is contraindicated on or near patients with any electronic medical device. For example, cardiac pacemaker, transcutaneous electrical nerve stimulator, TINS, insulin pump, or patients with delayed healing as a result of debilitating disease or radiation therapy. It is not suitable on thin attached gingiva. It should not be used with metal instruments because contact could cause electric shock. Profound soft tissue anesthesia is mandatory. A thin wire electrode is best for sulcal enlargement. Gingival contouring is usually performed with the loop electrode. The instrument should be set to unmodulated alternating current mode. The electrode should be passed rapidly through the tissue with a single light stroke and kept moving at all times. If the tip tracks the instrument is at too low a setting, and the current should be increased. If sparkling is visible in the tissue, the instrument is at too high a setting and the current should be decreased. A cutting stroke should not be repeated within 5 seconds, and the electrode must remain free of tissue fragments. The electrode must not touch any metallic restoration. Contact less than just 0.5 seconds has been shown to lead to irreversible pulpal damage in dogs. The sulcus should be irrigated with hydrogen peroxide before the displacement cord is placed. There is also a soft tissue laser. Soft tissue lasers have been advocated as a means of removing a controlled amount of tissue before impression making. They are also useful for tissue contouring procedures. Currently, the process of impression taking is regarded a combination of the scientific approach and creativity. The crucial element of the procedure is the optimal choice of both the material and method. The variety of impression materials, different in their physicochemical properties and indications for application, are used in contemporary dentistry. Thus, the awareness of this is important to make a proper choice of impression material for various clinical cases. Impression materials can be classified according to their composition, setting reaction, and setting properties, but a commonly used system is based on the properties which occur after the material is set. Properties of impression materials. Viscosity. Substances with low viscosity are characterized with high fluidity and vice versa. The viscosity of the substance increases with the percentage of filler. Thixotrophy is the property of the substance to flow when under compression and keep its shape when in static condition. Materials with low viscosity are also called corrective or spreading. Flowable, they allow defined details to develop on the surface, but in practice, they are not used on their own. Corrective mass is often used together with more thick substance, which supports a low viscosity substance providing hydraulic pressure. Hydrophilicity impression materials are characterized by hydrophilicity of different degree. They can be hydrophilic, hydrophobic, and hydroactive. Hydrophilic substances are characterized by high affinity towards humidity, good wettability, and imprint the smallest details on the surface. Hydrophobic impression materials have low moisture affiliation, characterized by poor wettability and small details imprint insufficiently. Hydroactive materials are common hydrophobic substances whose hydrophilicity is enhanced due to the increase of the surface. As a result, surface high wettability and ability to imprint the details are achieved. Setting time of impression materials includes the whole period from kneading up to the complete hardening of the substance, when it's possible to remove the impression out of oral cavity without deformation. Working time is considered from cleaning up to the moment when manipulation of the material becomes impossible without deformation of the possibility of taking correct impression is missed. Impression material should be completely kneaded and placed in the oral cavity before the working time expires. Since the temperature of the environment has its impact of the setting time of elastomeric impression materials, one of the ways to increase the working time is to cool the substance before kneading. Cooling impression materials by 2 Celsius degrees allows to increase the working time by 90 seconds, but applying auto-mixing tips or devices, cooling of the material must be carried out with caution. Besides cooling impression materials to the temperatures lower than plus 18.3 Celsius degree, in different ways change the flowability of the main substance and catalyst leading to the disturbance of their proportions. Factors affecting the working and setting time are humidity, basis and catalyst ratio, as well as the method of substance kneading, dimensional stability. Accurate imprint of the intraoral structure on the impression depends on its dimensional stability. Dimensional distortion of impression can be conditioned by different causes, polymerization, shrinkage, byproduct release in the processes of the seed impression material, environmental humidity, or absorption of oral fluid, as well as temperature change in the environment. Substances with high dimensional stability in practice are unchangeable within approximately 7 days, regardless of the temperature change in the environment. Moreover, it should be possible to pour several precise casts from these materials. Shear resistance and elastic recovery. Impression material should be firm enough to be removed from oral cavity without damage. Rupture. Substances with high tear energy provide the impression with high tear resistance. Elasticity allows the substance to resist tearing and come back to initial configuration, but every substance has elasticity limit which, when exceeded, makes reverse to primary shape impossible. A substance is preferable to tear rather than undergo permanent deformation, at least within the finish line and inside the gingival sulcus. Permanent deformation depends on the stretching degree of sutured polymer, temperature, and expression of applied loading. Mentioned physical properties such as tear resistance, lasting recovery are very important in getting precise impression, taking it out of the oral cavity and separation from the cast. Impression material should have a high tear resistance and elastic recovery to make it possible to get several casts out of one impression. This property is considered as an advantage in the contemporary restorative dentistry. Alginates, they are hydrophilic, moisture tolerant, so it can be used even in presence of moisture in the oral cavity, which is challenging with hydrophobic materials. Dentists consider these substances to be quite accurate, easy to use, and patient-friendly, though it requires accurate measurement and route needing. The traditional need for careful attention to set time accuracy is less challenging with the phasic materials which are now available, which change their color indicating the precise time for the tray to be set in the oral cavity and when to start timing the final set. The clinician must also take care to avoid pulse, which can cause distortion during removal. Due to its flexibility, it is easily removed from the mouth compared with the other materials if they flow into undercuts. While using alginate impression, the cast should be parted within 10 minutes, otherwise it will be deformed. To avoid distortion, the impression is kept in a humid environment. They can be wrapped in a wet paper towel or stored in a plastic box that is designed to contain humidity. Alginate materials are mostly used for study models, diagnostic workups on sets of mounted models, trial equilibration of standard models to the laboratory to have a boxed up completed. They can also apply to make a complete of partial removable dental prosthesis.